Hello and welcome back to Medical Today. I'm Jared Rutnam and I do hope you're having a lovely Saturday wherever you are. Well, on the show, we did cover a little bit about advertising a while ago. From there, we want to move into diseases and we want to talk about a disease that does not discriminate. It's no longer for the old. Everyone gets it. It's a stroke, and everyone's heard about a stroke or know of someone who has a stroke. But what actually is a stroke? The details of it. We'll give you some insights as we move along. Joining me in the studio is Dr. Ramesh Narendiranathan, a consultant neurosurgeon from Ramsay Sime Darby Healthcare. Doc, very good day, and thank you very much for joining us on Medical Day. It's good to have you here.
It's my pleasure being here.
Well,
thanks for calling me.
When we talk about strokes, like I said earlier, it doesn't discriminate. What's your, if you want to give us a brief overview on this, where would you start?
All right. Strokes traditionally have been accepted as a disease of the age. Aging blood vessels, the medical conditions or the non-communicable diseases, heart, blood pressure and diabetes that comes with it. But there's another group of patients who actually present with strokes at a much younger age. It can be as young as a child to under 50. In fact, the age between 35 to about 50 has got a risk of stroke.
Now, let's very quickly move into the causes of the stroke, because there's just so much to cover when it comes to the stroke. And we've got 3 different areas we want to try to cover today. So we'll start with the causes of the stroke in the young. Give us your thoughts about this, and what are the causes?
All right. The causes of strokes in the young are aneurysm, brain aneurysm, brain arteriovenous malformations, cavernomas, moya disease, and there are many other small vascular abnormalities. All these are due to vascular abnormalities, blood vessels in the brain having some abnormality which ruptures and causes a stroke.
Now, when you look at the stroke, the most common causes of a stroke, let's walk into that area now. What are the most common causes? As a doctor who's been practicing for many years, and I'm sure you've done your own research, what would you think is the most common?
The most common that we see in the younger age group is actually an aneurysm. A rupture of an aneurysm which causes a stroke.
Right. So if you're going to expand and explain to us what an aneurysm is, what would that be?
All right. An aneurysm, is how I put it to my patients, sometimes it's like a balloon. It's a bulge from the blood vessel. It bulges out like a balloon. And as the balloon grows bigger, the walls become thinner, and it suddenly ruptures into the brain, causing severe headache or stroke.
So the symptoms can be severe headaches, but there's an aneurysm, but there's also an arteriovenous malformation now, or an AVM.
Yes.
Yeah. So what's the difference? Can you differentiate between these two?
Right. An arteriovenous malformation is a tangle of vessels between the inflow of blood into the brain and the outflow of blood from the brain. Again, to put it in layman's terms, is like your highways. From your major highway, you have your trunk roads to your town roads and right down to your village roads. And the blood returns the same from the small vessels right up to the major vessels. Now, if there's a shortcut between the major vessel and a major outflow vessel, then there's a high blood flow in the outflow vessel. And this potentiates the risk to rupture and cause a stroke.
Now, the risk factors for an aneurysm, maybe you can walk us through the risk factors.
The risk factors commonly is smoking, high blood pressure.
All the things we like to do, huh?
Yes. Family history, okay. The age over 40, so in that 40 to 50 has a slightly higher risk of for having an aneurysm. Unfortunately, women are more prone to having an aneurysm as well. The ratio is about 3 to 2.
In the same age group, 40 to 50?
Yes.
Yeah. And this is because of unhealthy choices in lifestyles?
No.
Yes and no?
No. In the younger age group, it's a bit too early to see the effects of the unhealthy lifestyle. Unhealthy lifestyle for a long period of time is going to cause you problems as you age. So in this younger age group, it's not a healthy lifestyle. It's going to be difficult to prevent this. Okay, except maybe drug use, which is another risk of having an aneurysm. That's the only thing that is probably preventable, and of course smoking.
Right. So if we're going to lay out the risk factors very simply, the risk factors once again would be smoking and high blood pressure, of course. That's sometimes uncontrollable with the working lives we lead. You know, some of us are very stressed. Now, let's talk about the preventable measures with regards to aneurysm and AVMs.
Unfortunately, this blood vessel malformations, except for aneurysm, which has got some factors, AVM, we still do not know what causes them. Cavernomas, we do not know what causes them. So it's going to be quite difficult to prevent them.
Right.
The only thing I can say is the moment you start having symptoms or early signs, get to see your doctor immediately.
Now we need to move a little quicker and talk about the symptoms or presentations with regards to these problems. You know, what are the symptoms? What will you feel when these things occur to you?
Okay, aneurysm classically presents with a sudden onset of severe headache. I usually ask my patients, because everybody experiences a headache now and then, and I usually ask my patient, is this the worst headache in your life? And this is actually a standard cliche for us to diagnose that this patient has had a potential rupture aneurysm. Other milder, not so common symptoms that we see is sometimes you can have pain at the back of the eye. You can have a drooping of the eyelid, what we call ptosis.
Right.
Okay. What sometimes people call lazy eye may actually be suggesting of an impending rupture of an aneurysm.
Right.
Okay, neck pain. Once
Not a rupture, but an impending rupture.
Impending rupture.
Now,
Right.
okay, with that, we also need to look at how quickly we can diagnose and what kind of diagnosis.
Right. The moment the patient comes into the hospital, we suspect it's a ruptured aneurysm, the first thing done is a CT scan of the brain. A CT scan will show us the hemorrhage within the fissures of the brain. Once that is done, once we are aware of that, then we need to confirm that the aneurysm and where is the location of the aneurysm. Now that is usually done by classically by the conventional angiogram, where a catheter is inserted into the artery, a small tube is put up to your brain, and dye is injected and pictures are taken. Now we have more modern techniques, what we call a CT angiogram, just like going for a CT scan. Nothing invasive, nothing going inside your body except the contrast is injected.
Right.
And a picture is taken which can actually show us a three-dimensional view of the aneurysm with relation to its parent blood vessel. So actually gives us an idea how to treat the aneurysm.
Right. So, but if you're speaking of the gold standard of diagnosing, which treatment would it be?
The gold standard has still been angiogram. So if our CT angiogram is negative, then we will have to do a conventional angiogram for the patient.
So once someone is diagnosed or it's been ascertained that someone has these problems or has a stroke, what is the treatment that can be provided straight away?
Right. So now to treat the aneurysm, the first thing we need to do is to secure the aneurysm because of the risk of re-rupture. Right. So there are two options. One is what we call a less invasive method, that's using the angiogram again, just like how in heart surgery they do ballooning and stenting of the heart blood vessels. Here, using this fine microcatheters, you actually put coils into the aneurysm, so the aneurysm thromboses off.
Right.
Okay. The other option actually is standard age-old this thing of microsurgery, where we go in, identify the aneurysm, and actually put a clip across the neck of the aneurysm.
Right. But with these things, there are pros and cons. What are the pros and cons?
Right. For this coiling of the aneurysm, as we call it, using the angiogram catheter, if the aneurysm is of a wide neck, then the risk of the coils not sitting inside the aneurysm well is one risk. The other thing is can be location of the aneurysm. Like we know an ACOM aneurysm, if it's projecting, that's in the front of the brain, if it's projecting anteriorly and superiorly, up and forwards, they do better with surgery. Whereas if they're projecting backwards and downwards, they do better with coiling. So based on these features of the aneurysm, we actually decide whether coiling is more suitable or open surgery is more suitable. So
this also goes back to the surgeon's experience and what he thinks needs to be done. His advice is very important.
Yes, his advice is important, but unfortunately our population, a lot of them are afraid of brain surgery, and everybody wants a minimally invasive route, which sometimes doesn't help them in the long term.
Right. Right. Now, just a quick question about a complex or giant aneurysm, which differs from what we're talking about. So there's something bigger to deal with.
Yeah, and aneurysm classically, of course, there's also the ones that we call an unruptured aneurysm. So any aneurysm which is less than 6 millimeters in size, I don't actually offer treatment. Because the studies have shown that their risk of rupture is low. So anything more than that is, we need to treat them. Or if it ruptures, they must be treated. The giant aneurysms, actually, those are more than 2.5 centimeters. Now, interestingly, we have tried with coil embolization and failed and had to go for bypass surgery. So some of them I actually have chosen to do a bypass surgery where I close off the blood vessel with the aneurysm because it's too big to be clipped without blocking the blood flow, and then bring in a bypass from a blood vessel outside of the skull into the brain to supply the brain.
Now, when you talk about bypass surgeries, it starts, when you have to talk about it, it starts to worry people. What's your advice with regards to bypass surgeries? You know, should it be done? Should it not be done? What's the word out there with regards to bypass surgery?
Right. This is actually going to be depending on the case by case basis, depending on the disease they have and what are the best treatment options available. Right. I've had one patient who had a giant aneurysm in the intracranial artery, or the ICA as we call it, and he refused surgery. He insisted on trying the coiling, so it was coiled. In the first year after that, it was coiled very well. If we look at the post-angiogram pictures, it's perfect. A year after that, it reopened. So this is where sometimes coiling is not suitable. So then we had no choice. We had to put in a bypass, get the blood flowing to the distal part of his brain, and then close off the primary blood vessel which had the large aneurysm.
Now that we're running out of time, very quickly, your advice to all of us with regards to aneurysms, strokes, so on and so forth.
The moment you have a problem, if you have a headache or you have recent onset of headaches, get to see the doctor as soon as possible. If you're one of those with frequent headaches, it's best to get a scan or an MRI of the brain done at least once in your lifetime.
So the final word is to get a scan done if you have frequent headaches. Don't leave it be.
Yes. And if you have sudden severe headache, rush to see a doctor immediately.
Right. On the note, Dr. Ramesh, it was a pleasure and an honor having you here on the show. We do hope to have you back again to bring us more about strokes and different diseases that are in that same stable which needs to be talked about. We just spoke to Dr. Ramesh Narendranathan, consultant neurosurgeon from Ramsay Sime Darby Healthcare. Thank you very much for staying with us right here on Medical Day. We'll be back just after a break. Stay with us.